The webinar
Welcome
is starting.
all to the 11th e-class which we are conducting. Today we have the esteemed professor of cardiology, retired from Usmania Medical College, Professor Krishnam Raju. Then we have Dr. Shiba Takar Chabra from Ludhiana, Hero DMC. And also we have Anupam Bamani from AIMS Partners. So with this expert examiners, we're going to have a case presentation, and that's by from Andhra Medical College, Dr. Vamsi Krishna. Vamsi, I think you can proceed.
Yes. Good evening, respected faculty. I am Dr. M. Vamsi Krishna, second year postgraduate, Andhra Medical College. Today, my case presentation is on patient who is aged 69-year-old male patient who is occupation by farmer and he belongs to lower socioeconomic status. He presented with chief complaints of shortness of breath since 7 months, pedal edema since 3 months, palpitations since 3 months. History of presenting illness. Patient was apparently well before 7 months. He developed symptoms of shortness of breath 7 months back while doing his sequestration drug, which is farming, and initially got relieved by taking rest. Since 5 months, the patient was unable to continue his work, which is farming, due to shortness of breath, which did not decrease with rest and associated with increased fatigue, and occasionally had nocturnal episodes of breathlessness 2 hours after going to sleep, for which he had to rush to the window for air, which relieved within 15 to 20 minutes in upright posture. He used to take some medications from local pharmacy, which increased his urine output, and the symptoms temporarily decreased by taking these medicines. After 2 months, his shortness of breath even progressed to even on rest, which is aggravated on lying down position and relieved with assuming upright position. And it is associated with increased fatigue, palpitations, pedal edema. And for these complaints, he was admitted in a hospital and was treated. The palpitations since 3 months were regular, felt as thumping, and increased on minimal exertion while doing his regular activity, not as a dizziness, and decreased on taking rest, and there is no history of post palpitational diuresis. The pedal edema, which is since 3 months, it is bilateral pitting type, not associated with pain, present up to ankle level. No redness or no abdominal distension is present. No history of decreased urine output, nocturia or hematuria is present. The patient had complaints of weakness of left upper limb with deviation of mouth towards the right side during the hospital stay 3 months ago. Now he presented with similar complaints of to the KGH with similar complaints of shortness of breath at rest since 10 days, associated with fatigue, pedal edema, orthopnea, and palpitations. It is not associated with chest pain or no history of decreased urine output. No history of hemoptysis is present. No history of hoarseness of voice or decreased swallowing. No history of decreased urine output. No history of fever, cough, or wheezing is present. Coming to past history, there are no history of similar complaints in the past. He is a known hypertensive since 3 years on medication using irregularly. He is not a known diabetic. Patient is unable to recall any history of joint pains or nodules or skin rashes, nodules on the skin or rashes on the skin, and no history of usage of antibiotics or injections on regular basis previously. Family history. He had he was born out of non-consanguineous marriage. He is the third out of 3 children. He had 3 children, and none of them had similar complaints, and there are no similar complaints present in the family. Personal history. Patient is a known alcoholic and smoker. He takes mixed diet. Had decreased sleep since past 3 months. No normal bladder and bowel habits are present. Treatment history. He is using tab atenolol 50 mg since 3 years for his hypertension, which he is using irregularly. 3 months ago, when he was admitted, he was kept on dual antiplatelets and statin for CVA and diuretics and vasodilators. Summary: 69-year-old male patient non-alcoholic smoker, presented with gradual onset dyspnea, which progressed from NIHA 2 to NIHA grade 4, associated with episodic orthopnea, PND, palpitations, fatigue, and bilateral patellar edema, which are relieved by taking medication, with no complaints of chest pain, syncope, abdominal distension, fever, and no feature suggestive of infective endocarditis. My differentials are valvular heart disease with probably regurgitant lesion, dilated cardiomyopathy, or ischemic heart disease.
So, Dr. Vamshi, you said that patient, if I'm not wrong, you said for last 2 years, he has class 4 dyspnea, which was for some time reduced with medications, but now it has worsened again. Is that right?
No, ma'am. His symptoms started 7 months ago. 2 months
No,
ago,
no.
he had a 3 month.
When did he develop class 4? When he deteriorated from class 2 to class 4?
Uh,
First time, when did he
Initially 7 months
deteriorate?
ago,
7 months
when
ago,
2 months back, 3 months ago, ma'am. 3 months ago, ma'am.
3 months ago.
Was
Okay,
this the
fine.
time when he was hospitalized with CVA?
Yes, ma'am. Yes, for SOB, he was hospitalized, ma'am. And during his hospital stay, he had a CVM.
Was he
Mhm.
hospitalized when he was in class 4 and he presented with pulmonary
Yes,
edema?
ma'am.
That was 3 months back. Okay.
Yes, madam.
Vamsi, can you summarize Professor Krishnam Raju has joined the meeting. Just can you briefly summarize quickly in 2-3 minutes? Sir, welcome, sir, to the WinCars class.
He is a 16-year-old male patient who is working as a farmer, presented with shortness of breath 7 months ago, sir, which was initially relieved on taking rest. Now, since 5 months, it was since 5 months he was unable to continue his work due to shortness of breath, and it did not decrease with rest. It is associated with increased fatigue, episodes of PND, sir. In the last 3 months, he had the shortness of breath even progressed to on lying down at rest and on lying down, and it's improved with assuming upright position, associated with increased fatigue, palpitations, fatal edema, for which he was hospitalized. During hospital, the palpitations since 3 months were regular, felt as thumping, increased on exertion, and while doing his regular activity, and not as well dizziness, decreased on taking rest. Fatal edema since 3 months, bilateral bleeding type present up to ankle level. Patient had a history of weakness of left upper limb with deviation of mouth towards the right side during the hospital stay 3 months ago. Now again, he was presented with the similar complaints of SOB at rest, SSL fatigue, fatal edema, orthopnea, and palpitations 10 days ago. There is no history of similar complaints in the past. He is a known hypertensive since 3 years. No significant family issues. He is a 69-year-old male patient, non-alcoholic and smoker, presented with gradual onset dyspnea, which progressed from NIHA grade 2 to NIHA grade 4, associated with episodic orthopnea and episodic PND, palpitations, fatigue, bilateral fatal edema, which are relieved by taking medication, and not as one with no complaints of chest pain, syncope, abdominal distension, fever, and no feature suggestive of infective endocarditis. My differentials are valvular heart disease, probably regurgitant lesion, dilated cardiomyopathy, ischemic heart disease.
I have to give reasons why you are considering these three diagnoses, and which one is this in a particular order, or this is a random order of your choice?
No, sir. The patient had a shortness of breath, which was started 7 months ago, sir. And having long duration and associated with palpitations and fatiguability and fatal edema, sir. So there is a possibility of valvular heart lesion, valvular heart disease with regurgitant lesion, and patient is a known alcoholic, sir, and with and is an old age patient. So dilated cardiomyopathy is one possibility, sir.
Why can't it be the first possibility? He is 69 years, he is an alcoholic.
Yes, sir.
So, for argument's sake, I would say that dilated cardiomyopathy, or even better than that, ischemic heart disease is the first possibility, taking 69 years into consideration.
Yes, sir.
So, I would reverse it. I would think from the history, ischemic cardiomyopathy is the first possibility, dilated cardiomyopathy second possibility, and third possibility is some kind of severe valvular heart disease, maybe degenerative valvular heart disease rather than rheumatic, keeping in mind the age of the patient. So, I mean, what arguments you have against my suggestion? Hello?
Sir. Sir.
Now, what arguments do you have if I put them in that order? Ischemic cardiomyopathy, non-ischemic dilated cardiomyopathy, and then degenerative valvular heart disease.
The patient had no history of chest pain, sir. So, and not a known diabetic, sir. So,
Are they essential to make a diagnosis of ischemic
no,
heart
sir.
disease?
No,
Neither
sir.
chest pain is essential,
No, sir.
nor diabetes is essential.
Yes,
What
sir.
is the commonest heart disease at the age of 67, 69,
Ischemic heart
70?
disease.
The commonest heart disease these days is ischemic heart disease,
Heart disease.
statistically speaking.
Yes, sir.
We are not talking about 1960s and 70s. We are talking about 2020s. So in 2020s, the first diagnosis should have been ischemic heart disease, ischemic cardiomyopathy.
Yes, sir.
So I mean, you probably are biased by your auscultation findings, but I must tell you that at each level, you have to ask yourself what is more likely from the available information. At the end of the story, it is possible that we may discard all this thing and step into something else.
Yes, sir.
But you need to take into consideration everything into your calculus, the age of the patient, gender of the patient, and then the symptoms. Okay.
Yes, sir.
So I don't know what other panelists feel. May I hear from the other panelists, please?
Sir, we totally agree with you. At this age, with these symptoms, I think ischemic heart disease definitely should be the first possibility.
Yeah. May I know your name, madam?
Sir, my name is Anupam, and I'm from AIIMS Patna.
You're from?
Sir, AIIMS Patna.
AIIMS Patna. So if I remember right, you are Dr. Anupama, isn't it?
Yes, sir.
Okay. Thank you for answering that. I think my own thing about his presentation is initial thing I was finding difficult to get into the Zoom, so I did not hear. But from the diagnosis he is giving, I think his order is incorrect.
Thoroughly agreed with you, sir. I mean,
Yeah. So now, can you go further on?
Yes,
in
if
your
you permit,
presentation?
may I
Yes.
ask a question to Vamsi?
Yes, ma'am.
Please go
Yeah.
ahead.
So, Dr. Vamsi, there are 2-3 things when we heard your history. While you were presenting, you said no history of joint pains in the past, and in how many cases do you expect that you should be getting a history of rheumatic heart disease? At 69 years, we are taking history. Am I
Yes, ma'am.
audible?
Yes, ma'am.
Yeah, and another thing is that once you said that if at all you placed a valvular lesion, as Sir rightly pointed out, that we think of degenerative more than any rheumatic process. Why do you think regurgitant only? Your patient, what is in favor of a regurgitant vis-a-vis a stenotic lesion in your case?
Uh,
So two questions for you.
there is history of palpitations and palpitations and increased fatigability, um, um, and the palpitations are regular. Usually in stenotic lesions, there will be more of irregular uh, uh, palpitations will be there, and uh,
So,
But
but you also
Vamsi,
have an associated very prominent symptom of dyspnea and
yes, ma'am.
orthopnea, which
Yes,
has
ma'am.
been there for the last 7 months.
Yes.
So, do you expect that to be because, this is what you said. So, how do you explain those recurrent episodes of PND and orthopnea in your patient? In fact, palpitations have been coming only for the last 3 months,
Yes,
right?
yes, ma'am. Um, as in this patient, it could be due to volume overload. During the night time, the PND episodes could be due to decreased sympathetic activity or any due to on lying down position there could be increased venous return during the night and um,
So your
and,
predominant symptom was PND and orthopnea, which actually started for the last 7 to 8 months. And for the last 3 months, he has started developing palpitations, which are there on exertion. Is
yes,
this how the usual natural history of any chronic severe regurgitant lesion is, or is it different?
different. Initially, palpitations would be more prominent than
Yeah, it
other.
will be long standing and a
Yes,
longer history. So you cannot say that you are not thinking of, a stenotic lesion. And as sir rightly pointed out, that once somebody is beyond in his 60s, you think of ischemic heart disease. PND can be very well, be explained even in ischemic episodes that the patient might be having. So, why would you ask for a history of rheumatic? Do you expect someone to present with at 69 years with rheumatic first thing? And if at all, you expect how many percentage of patients actually give a history of rheumatic heart disease?
less than 1%. It is not common in the old age.
Dr.
Okay,
Vamshi,
if it
you have to give a very, very clear answer to the question of Dr. Shiba because it's a very, very important and very frequently asked question in the DM, especially DM examination.
Yes,
What percentage of patients of rheumatic heart disease have history of rheumatic fever in the past? So it cannot be a vague answer. So try
yes.
to answer very specifically.
0.13%.
Uh, I think that's a bit too wild. That is too wild a guess. So,
so,
okay, but I think in exam, please don't make, and somebody has answered in the chat box. That is the right answer. That's 50% of the patients. And one question from my side, if you said that patient had class 4 dyspnea and
Yes, ma'am.
PND also. So
Yes,
if a patient is at rest as soon as he lies down, or if the patient is dyspneic all the time, whether he is taking rest or lying or working, so how would you diagnose PND? What symptoms will appear? Because in any case, when he was in lying position or sitting position, he was dyspneic. So what symptoms appeared which made you think that there was PND also? He was already dyspneic, right?
yes, ma'am. Madam, he
So,
started developing 5 months ago. He started developing sudden onset episodic shortness of breath during the night time, ma'am, which lasted for 15 to 20 minutes. When he had to rush to the some window to get to feel the air.
Dr. Vamshi, that you are describing the way it is described in the book, that how do we diagnose PND? But
Yes,
when in presenting the case, you said patient had class 4 dyspnea and he was
yes,
having PND also. So
yes,
class 4 means you are
okay.
conveying that he was dyspneic when he was at rest.
Yes,
So when somebody is already dyspneic, so what was additional thing which developed, which you thought was suggestive of PND? Because dyspnea is dyspnea, patient is already dyspneic.
Yes.
So what extra do you, is there something or how did you take the history of PND in a patient who was dyspneic all the time?
Actually, what Vamsi is describing, Vamsi, is orthopnea.
Yeah, Vamshi, so this description is not correct. So be careful while choosing your terminologies.
Here I have a question to Vamsi, which is very, very important, contemporary, and commonly asked in the examinations, is what is the ICMR data over a period of time? There had been 5 ICMR data that have been available, the last one being 2002. So you must be very familiar with all the data of these 5 ICMR studies, which is Indian data, and the last data being 2002. So now question to you, Vamsi, is what does it say about the incidence of or prevalence or incidence of rheumatic heart disease in Indian population according to the ICMR 2002 data? So most of the numbers which you seem to have in your mind, they belong to 60s and 70s. They have changed over a period of time. Now you need to know our own data. Now, according to 2002, what is it you know about the prevalence of rheumatic heart disease in India?
0.5
Where
to
was
2
the
per
study done?
1,000.
What are the numbers? It is very important. All the 5 studies need to be known to you.
1 to 1.5 per 1,000 populations. 1.5 to 2 per 1,000 populations.
What is the minimum that was reported? What was the maximum that was reported? Minimum reported was 0.5 per thousand. Maximum reported was 3.5 per thousand. And then the mean was, as you said, 1.5 per thousand. So which means that it is not really that common a disease of late. We are talking 22 years after the last study. Now I have a question to you. How many patients of rheumatic fever you have seen in your last 2 or 3 years of your training program?
2 to 3, 2 patients.
Based on what?
Joint pains. Patient had a joint
No,
pains.
here the questions will pop up about the criteria, Duckett-Jones criteria. What are the first criteria came in 1948. Then again 5 revisions have been there. So the obvious question will be, what are the Duckett-Jones criteria and the latest? And what is the WHO criteria? And then does the criteria include echocardiographic findings? And when was it included? And what are the echocardiographic findings which are taken into the calculus of the criteria? So these are the common questions that are being asked. I will not go into the answers because we have a limited time. And other questions that are commonly asked are what are the epidemics of rheumatic fever which are recently described in the world? One was in Utah, United States. Then you had one in New Zealand, right? One in Australia. And I think there was one in Belgium. So there will be some questions on epidemiology of the rheumatic fever and also rheumatic fever vaccines, Duckett-Jones criteria. So these are the ones which you need to know, including obviously the ICMR data, which is our own data.
Yes.
Am I clear?
Yes, sir.
Now, I don't want to go into discussion of that because it's going to consume a lot of time. Then other common questions that are asked are, in the available epidemiological data in India, so what is the incidence of erythema marginatum? What is the incidence of rheumatic nodules? And then what are the Indian criteria? You know, there are Indian criteria as well. From the Cardiological Society of India, there are Indian criteria. So what was included in the Indian criteria, which is not there in the other world criteria? Do you have answers, or we'll move on?
I will.
Please go back and read. I know the
Yes.
answers, but we don't have so much of time because it's only one.
Yes, sir.
Other panelists, please, if you have any questions.
Would it be hypertrophic cardiomyopathy? Anything against that? What are the points in favor or against? Could it
Patient
be
doesn't have any
hypertrophic
syncopal.
cardiomyopathy?
Patient doesn't have syncopal episodes, and
What is the usual natural history? Do you expect hypertrophic cardiomyopathy to present at 69 years?
chest pain should be there. Chest pain, shortness of breath, and
Is syncope a common presentation of hypertrophic cardiomyopathy? You said your patient had orthopnea, PND, episodes of exertional dyspnea, no?
yes, ma'am.
But
No,
then he
if
is 69 years of age.
can hypertrophic cardiomyopathy present as dilated cardiomyopathy?
Yes, sir. Yes.
So
Can
what
present
will,
with prolonged burnt out hypertrophic cardiomyopathy can present as dilated cardiomyopathy.
no,
In
end
the
stage hypertrophic
end stage hypertrophic
cardiomyopathy,
cardiomyopathy. Yes, sir.
it is called as dilated hypertrophic cardiomyopathy. That is a designation that is given. But hypertrophic cardiomyopathy to present as dilated cardiomyopathy is quite uncommon except in the end stage.
Yes, sir.
Then how does it present? It presents with chest pain. It may present with shortness of breath, particularly exertional. Those are the common presentations. Syncope is much less common.
Yes, sir.
What is the risk levels of sudden cardiac death in hypertrophic cardiomyopathy? Epidemiologically speaking, what is the percentage? It varies depending on the subtype, you know. The obstructive hypertrophic cardiomyopathy with the high risk features, it is 8% per annum. And then non-obstructive, something like apical hypertrophic cardiomyopathy, it is roughly 2%, 1.5 to 2%, less than 2%. Intermediate risk is about 5%. These are the people who may have sudden cardiac death. This is the annual mortality rate, which is fairly similar number all over the world.
Yes, sir.
So does your patient fit into hypertrophic cardiomyopathy?
No, sir. Less likely, sir.
No, it's not less likely, least likely.
So if it was dilated cardiomyopathy, do you think his alcohol could be responsible?
Yes, sir. Yes, ma'am.
What is the alcohol intake of the patient?
What alcohol, what percentage, how many times binge drinking, how long he has been drinking,
So
and
you should.
what is the etiology of alcoholic cardiomyopathy?
He's taking alcohol since 20 years, sir.
Now, did you go into the details, his alcohol details?
Because you mentioned alcoholic, so you should mention, no, the alcohol years, the percentage consumed per day, and what is the total amount, because everything has a bearing at the end of the day, no?
Good thing about alcoholic cardiomyopathy, it could be reversible.
Reversible.
It is one of those few reversible cardiomyopathies. And another factor is many of these alcoholic cardiomyopathies may be beriberi as well, B1 deficiency. So it may be completely reversible. And religiously speaking, you should never miss a reversible cardiomyopathy.
So can you mention some causes of reversible cardiomyopathy now that sir has mentioned it?
Beriberi, nutritional cardiomyopathy, and alcohol. Any due to thyroid disease, probably any tachycardia-induced cardiomyopathies.
Tachycardia. What about Takotsubo syndrome?
Takotsubo, stress cardiomyopathy.
Can
Any
hemochromatosis be associated? Hemochromatosis be associated with dilated cardiomyopathy?
restrictive cardiomyopathy.
You have a whole lot of them: cirrhotic cardiomyopathy, obesity cardiomyopathy, and
Yes.
you have a sleep apnea which can produce a cardiomyopathy, and reversible ischemic cardiomyopathy, where once you do a CABG, once you restore the blood flow, the so-called ischemic cardiomyopathy has the potential to reverse if it is a hibernating myocardium.
Yes, yes, sir.
So there are so many things which are there, so which you need to understand: acromegaly cardiomyopathy, thyrotoxic cardiomyopathy, myxedema cardiomyopathy, right?
Yes, sir.
So pedal edema in your case is explained because of?
Madam, I didn't get.
Pedal edema. How do you explain pedal edema in your patient? You mean to say that patient is pedal edema and no abdominal distension and nothing?
Yes, ma'am.
So what does pedal edema indicate?
Due to
Patient.
interstitial, due to congestive cardiac failure. This patient due to volume overload could be due to right heart failure, secondary to valvular heart lesion.
No, you could simply say that right heart failure of any etiology.
Right. Yes.
Right?
Yes, sir.
And also constrictive heart disease or constrictive
Yes.
cardiomyopathy. The
Yes.
so-called restrictive cardiomyopathy, which was originally called constrictive cardiomyopathy.
Yes, sir.
All right?
Yes, sir.
Then is there any evidence of renal failure? For example, CKD with heart failure also is reversible.
No evidence, sir. No evidence of CKD in this patient, sir. No hematuria.
How do you know from the history? How do you know whether there is CKD or not? You will not know unless you look at the biochemical parameters.
Yes, sir.
The importance of knowing that is, once you do a dialysis or do a renal transplant, which can be completely reversible. That is one of the examples of reversible cardiomyopathy.
Yes, sir.
Did you finish your physical examination?
No, sir,
sir.
he has to start. Please.
Oh, we just have only another 25 minutes.
Yeah.
Can you go ahead, please, with your general examination and then physical?
Yes, sir. And in general, patient is conscious and coherent. He is moderately built, moderately nourished. He doesn't have pallor, rectus, or sinuses, clubbing, or lipidopathy. Pedal edema is present, bilateral painless between pedal edema extending up to ankle level. His height is 172 centimeters, weight is 74 kgs, BMI 25, upper segment 84 centimeters and lower segment 88 centimeters, probably 0.9 ratio, arm span of 170 centimeters.
Let me tell you something. When you are talking about, go back to general examination. When you are talking about general examination, you said pedal edema. You should say whether it is bilateral and symmetrical or asymmetrical.
Bilateral symmetricals.
Is there, it's painless, all right, but is there tenderness or no tenderness?
No tenderness.
Are there veins visible or not visible?
No, sir. No, sir.
Is there edema of the abdominal wall or no edema? Facial edema?
No, sir.
No, you don't have any of them. Then recently they have included in the general examination the girth of the neck, round circular girth of the neck, and also abdominal circumference. Because they are giving less importance to BMI now, they are giving more importance to abdominal girth and then the neck girth.
Yes, sir.
The reason is abdominal girth tells you about the visceral adiposity. And similarly, neck circumferential measurement will tell you about the status of whether the patient is likely to have a sleep apnea. Sleep apnea is a very important component which you should have. I don't know whether you have talked about it in your general symptomatology. So you should ask for nocturnal snoring. You should ask for daytime drowsiness, right? Whether there
Yes,
is any evidence of accidents while driving. All these things indicate a sleep apnea. Sleep apnea can present with heart failure or worsen heart failure, may present with multiple arrhythmias, including atrial and ventricular arrhythmias. So sleep apnea is part of cardiovascular interrogation now. Okay?
yes, sir.
All right then. Because this has become a glitch. All the students give the same numbers. Height, weight, upper segment, lower segment, but they're not keeping pace with the modern observations and modern literature. You are talking of valvular heart disease. You could have just mentioned there are no Marfan features. You could have also mentioned whether there are any musculoskeletal malformations. You should also have mentioned about thyroid, whether there is any thyroid enlargement. You haven't mentioned anything like that. There could be some evidences on external examination of the skin. For example, for hypertrophic cardiomyopathy and pheochromocytoma, right? There may be some skin evidences. So some relevant things you need to keep in mind when you have given a possible diagnosis. So these are the things which you have to go back, ask, and then present in your examination. Particularly
Yes.
thyroid and sleep apnea are very important components of cardiovascular evaluation.
Yes.
Am I clear?
Yes, sir.
Okay, go to the next slide.
Peripheral signs of aortic regurgitations. In my patient, the Corrigan sign is
No, they
present.
are not peripheral signs of aortic regurgitation. They are the peripheral signs of aortic runoff.
Yes.
Aortic runoff may be aortic regurgitation. It may be rupture sinus of Valsalva into right atrium or right ventricle or pulmonary artery, or it may be massive coronary arteriovenous fistula, or it can be a very big systemic arteriovenous fistula. It could be any of them. So I should say peripheral signs of aortic runoff. They are not signs of aortic regurgitation. Aortic regurgitation is one of the causes of aortic runoff. Am I confusing you or am I telling
No,
you
sir.
something
No, sir.
relevant?
Yes, sir. No, sir. I'm not confused.
Are you confused?
No, sir.
Because language is very important, how you put it across. Okay, go ahead.
Corrigan sign is present. Pulsus bispherians is present. Water hammer pulse is present. Pistol shot sounds. Drop sign is present. Urine sign is murmur is present, and Hill sign is present in these patients.
So here they will nail you on what is corrigan sign, what is bisvariance, what is significance, and they will also nail you on how do you make out Durocher's murmur, how do you look for it, and then the Hill sign is now taken off the list. If you have read the latest Braunwald, they give least importance to Hill sign. They don't take it as any significant sign at all. But however, your old age examiners like me might ask you, what is Hill sign? How do you look for it? What are the numbers? So you should at least know, having said that.
The Hill sign is it is a higher systolic blood pressure in the lower limbs than in the upper limbs. The difference of greater than 60 mm Hg denotes severe aortic regurgitation. Moderate AR means the difference of 40 to 60 mm Hg. Mild AR means 20 to 40 mm Hg.
What is the most important clinical sign of aortic regurgitation?
Durocher's murmur.
Of course, no. The most important constant presence is the early diastolic murmur,
Usually,
not the peripheral signs.
yes.
As I told you, peripheral signs may be present in a clutch of other diseases. Early diastolic murmur over the left parasternal border is the sign of aortic regurgitation, though it may be absent in some patients with aortic regurgitation due to various other reasons, which I will discuss later on. Murmurless severe AR is one thing which we always need to remember. Okay.
You've not so far told us, the blood pressure of the patient, and I agree, you've talked about Hill sign, but we need to, yeah. So yes, okay, you're coming to that. Did you finish this slide? Did I miss it?
No,
Because
no,
this
ma'am.
was, so this should actually come before the peripheral signs, We look for vital sign before the peripheral. So these, I was just waiting to look at them. Okay.
Pulse is 98 per minute, regular high volume collapse felt in all the peripheral areas, no radial or radiofemoral delay, no apex to pulse deficit is present. Blood pressure, left upper limb 120 by 50, right upper limb 120 by 40, lower limb 180 by 40 is present. Respiratory rate 19 per minute, thoracoabdominal. Temperature is 98.3 Fahrenheit. JVP is 8 centimeters above the sternal angle, measured with head and elevated 45 degrees. There are two positive and two negative.
Is this normal difference acceptable in the diastolic pressures in the upper limb and lower limb and between the two upper limbs? Am I audible?
Yes, ma'am. In the aortic
So,
regurgitation. Yes.
yeah. So what happens to the blood pressure? Is the diastolic pressure different between the limbs, or is it the same? What varies, the systolic or the diastolic in a normal human being?
Systolic.
Yeah. So, but in your slide, you said 40 and 50. Yeah, we usually don't expect this difference in the diastolic pressures, at least, but it's all right. It's less than 10 or maybe 10, but usually do not expect the change in diastolic pressures.
Yes.
So, what did you hear for the diastolic? Was it Korotkov muffling 4 into 5, or was it a simply loss of sound that you had?
Muffling. Korotkov muffling.
Yeah, so you can say Korotkov 4 to 5. Yes.
Examination. Inspection and palpation. The chest wall is normal in shape and it is symmetrical. There is no precordial bulge, no dilated veins, scars, or sinuses are present. Apical impulse seen and felt at 7th intercostal space at anteraxillary line. It is hyperdynamic. Supraclavicular pulsations and epigastric pulsations felt. No parasternal heave, no pulsations or thrills are present. Percussion, left heart border corresponds to the apex. The right heart border corresponds to the right sternal border. Left second intercostal space is Liver dullness percus at right fifth intercostal space in mid-clavicular line. Drop space is tympanic to percus. In auscultation, S1 is heard, it is soft. S2 is heard, there is narrow split. S3 is present and S4 is absent. Mitral area, a high-pitched, soft-blowing holosystolic murmur of grade 3/6 is heard with the diaphragm of the stethoscope conducting to the axilla, with patient lying down in left lateral position with breath held in expiration. In tricuspid area, a high-pitched, soft-blowing pansystolic murmur of grade 3/6 heard with the diaphragm of the stethoscope in patient in supine position with breath held in inspiration. Aortic area, a high-pitched, soft-blowing decreasing the early diastolic murmur of grade 3 heard with the diaphragm of the stethoscope, better heard in the second aortic area with patient in sitting and leaning forward position with breath held in expiration.
Now, when you are able to hear these murmur, go back. When you are able to hear the murmur in lying down position, why do you want to keep them sitting up, leaning forward, expiration, inspiration? Is it necessary? It's a waste of time, you know. You do all that only when you are not able to hear it in supine position, but you still have a suspicion that it is there. Then you do all those maneuvers. But if you are able to hear a grade 3 murmur in supine position, where is the need for you to do all these gimmicks? There is no need. Another thing is tricuspid murmur is always auscultated in quiet breathing, not in held inspiration. I don't know why you have done that.
Yeah, even for mitral regurg, typical description is for aortic murmurs, when we talk of held in expiration. Even in mitral area, you don't need to mention that the breath is held in expiration. And anyway, sir has said that when you are able to hear these murmurs so well, where is the need for making the patient, And
Yeah.
could you please show your apex beat? How did you describe it? Sorry, I mean,
Apex impulse is seen in seventh intercostal space at the anterior line. It's hyperdynamic and corresponds to L.
okay, so it's at the anterior axillary line. So it's a dilated apex. It's a hyperdynamic. All
Yes.
right. Any palpable, did you talk about palpation? Any palpable heart sounds or thrills?
No, madam.
Mhm. So no palpable heart sound, no palpable thrill. How do you explain your narrowly split S2? Go to the next on
Before he
auscultation.
answers that, I would like to ask, actually, how do you look for narrow split?
Hmm.
When do you say that there is narrow split? That is question one. Question two is, madams.
And even, sir, if you permit, how do we define splitting? How do we define splitting? When do we say that the splitting is narrow or wide? And then you answer this. Yeah. Define a normal split second heart sound.
Normal split is 10 to 20 milliseconds. And if it is more than 30 to 40 milliseconds, we call it a split. And usually
You
A2 comes before.
are talking in phonocardiographic terms, but we are talking about bedside examination. So how do you count those milliseconds?
So sir is asking that clinically, how would you say this is normal split? What is the clinical definition on examination? You don't have a phonocardiogram to calculate those sounds, no? So define a normal split clinically. How do you appreciate? So what is a normal? A normal split is having two components, A2 and P2. A2 precedes P2, and it's normally heard during which phase of respiration?
Expiration.
It's normally heard during inspiration.
Inspiration.
If it will be heard during inspiration as well as expiration, then it would be a
Narrow split.
oh.
Okay.
It will be a broad split,
Broad.
wide split. Wide split is the one which is heard both during inspiration and expiration.
Yes.
I think you are getting confused. Can you reframe your answer? What is normal split? What is narrow split? What is wide split? What is reversed split? What is paradoxical split? Because S2 is fundamental to clinical examination, particularly in valvular heart disease and congenital heart disease.
If inspiration, yeah.
Now you have A2 and P2 followed by P2. So if these two components are heard during inspiration, but they fuse during expiration, you call it as a normal splitting. But intensities are described separately. A2 intensity, P2 intensity. And then wide split is split heard both during inspiration as well as expiration.
Inspirations.
When
Fixed split is
A2 P2 interval is constant, you call it as a fixed split.
fixed split.
If it is heard both during inspiration, expiration, but during inspiration A2 P2 further widens, you call it as a wide mobile split. And then reverse split is P2 first, A2 next. That is reverse split. Paradoxical split is during inspiration, it is single sound.
Inspiration wide P2 and A2 in essence, or wide and split.
Lying down position, but you don't hear it on standing position. It is a somewhat ambiguous description for narrow split. Some people use it, some people don't use it, but that is part of the literature. But some examiners don't accept that narrow split thing. And I want you to remember the fundamental mistake you have done is you are talking in terms of milliseconds, which are the descriptions on phonocardiogram. And I don't think in my wildest dreams that you would ever have done a phonocardiogram on your own or have seen one. Have you?
No, sir.
Vamsi.
No, sir.
Then why are you talking of milliseconds? We are talking of clinical examination, so we are not talking of phonocardiology.
And can you also explain that how come a high-pitched sound would be soft blowing? Because in your murmurs, for aortic valve as well as mitral valve, you said high-pitched soft blowing. So how do we define a pitch when we are talking about, sounds in cardiology? Is there some definition for pitch? What are the typical 3 low-pitched sounds most of the times that we encounter in our clinical examination? Hutchison writes that line. The low-pitched sounds in cardiology are dash dash dash. Can you fill it up, and can you tell that how do we have the cycle lengths when we talk about the pitch of a given heart sound?
Which is also
So there are definite cycle lengths which have been described for the pitch, and the typical low pitch sounds, so less than 25 cycles, 25 to 75 cycles, more than 75 cycles per second. But more important is that at least we should know that what are the typical low pitch sounds. A murmur which is high pitched, why we should expect it to, because every murmur cannot be labeled as a soft blowing. You had the same labeling given for your, murmurs of aortic regurgitation, mitral regurgitation, So the murmurs, the diastolic heart sounds like S3 and S4 we would accept if you say they are low pitched, and of course if you're talking of diastolic murmur of mitral stenosis.
mitral stenosis.
Yeah. So
Actually, your
and
aortic registration murmur is decrescendo murmur.
yeah.
It is
And
not a blowing murmur. It is
yes,
a
and
deep
very important thing you missed, in the description of your aortic regurgitation murmur. I said that it's decrescendo, it's early diastolic. In diastolic murmurs, it's very important that we mention the duration of the murmur, because that is what is going to determine the severity of the. So
So
you have
is it
not.
short diastolic, early diastolic murmur or a long early diastolic murmur?
Long early diastolic murmurs.
How do you differentiate short versus long early diastolic murmur? When do you say it is long?
Continues up to the diastole.
No, once it crosses the mid diastole, it is
Yeah.
long diastolic murmur.
Less than half or more than half of the diastole. That's the typical.
Yes.
So you cannot afford not to mention. So coming back to the question, what was the cause of that narrow split S2?
You
Sir
had
just now told
something
you all
to
the causes.
explain. You had something to explain that in your original diagnosis. There is a heart failure, right side heart failure, secondary to left side. That's what you said. So how does right side heart failure happen to secondary to left side heart failure? There should be pulmonary arterial hypertension.
Sir.
Don't you think
Yes.
there is pulmonary arterial hypertension?
In this patient, there is no P2 or any palpable sounds are present, sir.
No, it need not be palpable. He is in heart failure. In heart failure, all the sounds are muffled.
Yes.
Because transvalvular blood flow is less. In your description of auscultation in S2, you have talked about narrow split, but you haven't mentioned the intensity of A2, intensity of P2. So your description itself is incomplete.
So are there some things which you were expecting to be there, which you looked for and you did not find, Because as Sir has said that you have a patient whose right side is involved, no doubt the patient is in heart failure. And so if the patient was in heart failure, what would you have expected which you haven't got? If the patient was not in heart failure and there was PAH and secondary right ventricular involvement, again, what you are expecting and what you have not got?
Loud P2 would have this loud.
So would you
Parasternal.
expect a parasternal heave?
Yes, yes.
And if the patient is in failure, as Sir is saying, the patient is maybe over the time developed LV dysfunction, has gone into failure, what is something that should have been present and which you have not at least found in your patient?
Yeah.
So what do we find, when a patient is in heart failure? What are the clinical things that you would expect? Would you expect any palpable S3?
Yes. Yes.
What is the cause of that murmur in the mitral area in your patient?
Mitral regurgitation.
Mhm. So your patient has got aortic regurgitation as well as mitral regurgitation, is having a dilated ventricle, which is in seventh intercostal space. What is the additional sound which you may expect? It's a very, and which you did not get. So you're not having signs of heart failure. You're not having an S3 at all, which is very actually surprising once you've got MR as well as AR, as well as a dilated ventricle and no PAH. And, we expect that maybe heart failure has developed. You're not getting an S3 also. What else?
S3 is present in this patient.
What? Achha, you said that?
Yes, ma'am.
Oh, did I miss it?
I was wanting to actually ask a question there. Is it left side S3 or right side S3?
Right.
LVS3s. Left front LVS3s.
But how do you know that? How do you distinguish the S3 LV from RV?
it is usually LVS3 is present at the apex felt.
No,
RVS3 usually
if the RV is dilated, RVS3 may also be heard at the apex.
and
How-
inspiration LVS3 could be increased during expiration, and RVS3 could be increased during inspiration.
They may not change if there is heart failure, because during inspiration, RV does not fill more if the RV is already filled enough.
With
So,
LVS3,
in the
features of
presence of heart failure,
heart failure
respirations may not make any difference whether it is LV or RV. If there is no heart failure, then what you are saying is right.
Can we differentiate between a left ventricular apex and a right ventricular apex on clinical examination?
Yes, ma'am.
So what is the difference? So which ventricular apex would have an area of, yeah?
Yeah, LV apex would be usually down and down. RV apex usually lateral, it will move laterally, not
So-
downwards.
So is this the criteria that we use in clinical examination or on an X-ray?
Clinical
What
exam.
is area of medial retraction and lateral retraction? So RV apex would usually be diffuse, right? There will be no area of a medial retraction, vis-a-vis in the left ventricular enlargement, where you will get an area of medial retraction. Very beautifully in Joule's constant, they describe the counterclockwise movement of the apex, which occurs vis-a-vis the movement of the above conotruncal segment, producing an area of medial retraction. So when sir is saying that patient has heart failure, and you may not because of that be able to know what you said initially, so at least you can define the type of the apex. What is
One
Austin
add-on
Flint
question.
murmur? Yes, sorry, sir.
Austin.
So please.
Now, suppose if there was S4, you have said there is no S4. Suppose if there was S4 in this patient, what lesion you can exclude comfortably?
Patient has force.
If there is
Regurgitant-
S4, there is no S4 here. What can you exclude if there was S4?
Aortic
Mitral stenosis. Mitral stenosis can be safely excluded if there is S4,
Yes.
provided the S4 is left-sided.
Yes, sir.
In mitral stenosis, there can be right side S4 due to PAH. So left side S4 excludes mitral stenosis very comfortably.
Yes, sir.
What is an Austin Flint murmur?
It is a metastatic murmur heard at the apex due to regurgitation, regurgitant jet effect of regurgitant jet on the anteromitral leaflet, fluttering of anteromitral leaflet due to regurgitant jet.
Could you have expected it in this patient?
Yes, ma'am. Yes.
Now, how is it produced, Austin Flint murmur? What are the hemodynamic correlates of Austin Flint murmur?
It is usually present in chronic aortic regurgitation, sir.
No, that is not right. It is present in severe aortic regurgitation, more often present in posterior eccentric aortic regurgitation, which impinges on the anterior mitral leaflet, leading to partial closure of the mitral valve. So during the diastole, when the blood is flowing from LA to LV, mitral anterior leaflet is partially closing. So that produces the mid-diastolic murmur.
So your patient also has MR.
Now, when can you have a severe AR without murmur?
Yeah.
Murmurless CR. Definite MR, but no murmur.
So sir's question is that you have acute AR, severe aortic regurgitation, but there
You
is
are
no
giving the
murmur.
answer.
It was a slip of tongue. But I wonder if he has got it.
Acute AR, acute AR.
Acute aortic regurgitation is one.
Yeah.
And second is when there is a heart failure, severe heart failure. Third is when the aortic regurgitation is posterior eccentric aortic regurgitation. Then you don't hear the murmur at all.
So
Yes, sir.
similarly, that's what sir has said, no? Even silent MS. You know what is silent MS?
Um, yes.
Silent mitral stenosis. Like sir told you, three very important causes, like aortic regurgitation is severe, but you're not hearing the murmur. Be it acute, be it heart failure, be it the posterior. So what is silent MS when you're not able to appreciate the murmur of mitral stenosis? That's got
severe
several causes. One of the causes could be like, the valve is calcified. But, one of the causes is also, again, that once the right atria, right ventricle are massively dilatation and there is a posterior shifting. So at times, you're not able to appreciate the murmur. So orientation of the heart also may have the effect, just like it might have an effect in a case of aortic regurgitation. But in presence of severe AR and severe MR, in fact, I was wondering in your history also. So you were not there in the history. You did not mention about nocturnal angina at all. So when you are mentioning of a severe valvular regurgitant lesion, and that so at least you should add nocturnal. Do you know what's nocturnal angina and what is the cause? Because it's very important.
Yeah. During nighttime, there is decreased sympathetic activity and decreased heart rate, causing increased diastolic time. It causes chest pain during the nighttime due to decreased blood flow to the heart due to increased diastolic time.
Many things happen in aortic regurgitation. One is there is a tachycardia. Your patient heart rate is 90 plus. So when the heart rate is on the high side, the diastolic period is shortened.
Yes,
And
sir.
two, when there is a leak across the aortic valve, coronary filling is affected because coronary filling happens during diastole.
Yes, sir.
Third thing is, if there is a flail aortic leaflet, that can be moving and blocking the ostium of the coronary artery. So it can produce a real angina. All right?
Yes, sir.
But you did mention paroxysmal nocturnal dyspnea. The so-called PND may have been a nocturnal angina. It may be a nocturnal anginal equivalent. You know the expression of anginal equivalent?
Yes, sir.
Okay, I think time is getting fast over.
Yeah.
We need to move on.
Yeah.
Do you have anything to show, like, for example, ECG, X-ray or something?
Sir. This is the ECG of the patient, sir.
Okay, go ahead with the diagnosis. What is your clinical diagnosis?
It is acquired valvular heart disease, probably of degenerative etiology, severe aortic regurgitation, moderate mitral regurgitation, functional TR, with presented with NIHA class 2, NIHA class 4, NIHA class 2, sir, with evidence of congestive cardiac failure, without pulmonary hypertension in sinus rhythm, without signs of acute rheumatic or infective endocarditis.
There are two holes in your diagnosis. One, how do you know it is degenerative etiology when two valves are involved? And second hole in your diagnosis is You are saying there is congestive heart failure with no pulmonary arterial hypertension. How does it happen in a left-sided heart failure, having right side heart failure and no PAH, if there is no right side disease? Then you have said functional tricuspid regurgitation. Third hole is, how do you know it is? These days we don't call it as functional, we call it as secondary. So we should call it as secondary tricuspid regurgitation. So why is it secondary tricuspid regurgitation? Why is it not primary valvular tricuspid regurgitation? You are contradicting yourself in your diagnosis. Did you understand the problem?
Yes. Yes, sir.
Do you agree with the problem?
Yes, sir.
So would you like to reframe your diagnosis?
The acquired valvular heart disease is probably of degenerative with the
Degenerative etiology may produce aortic stenosis. Does it often produce aortic regurgitation?
no, sir.
It may produce mitral regurgitation, it may produce mitral stenosis, it may produce aortic stenosis, but can it produce aortic regurgitation, generally speaking?
No, sir.
So your
No, sir.
degenerative etiology is thrown out of the ring.
Yes.
Now
Yes, sir.
here the questions will be, they will ask you, how do you know there is aortic regurgitation? 2, how do you know it is severe aortic regurgitation from your clinical findings? Then what are the evidence of mitral regurgitation? What is the evidence of moderate mitral regurgitation? You said there is S3, but when there is S3, don't you think it is severe mitral regurgitation rather than moderate? And then you are saying functional tricuspid regurgitation. How do you distinguish organic tricuspid regurgitation from secondary tricuspid regurgitation? Then how can there be congestive heart failure without PAH in a left side heart disease? So these are all the questions and holes in your diagnosis. Would you like to clarify any of them?
Would you like to go and re-examine your patient for a
Yes.
few findings?
Yes, ma'am.
What would you like to look for? And then rectify your. So as Sir
I'll
is rightly
want
said,
to look
you
for
would like to
some
look for features of
pulmonary hypertension and
Or what you are thinking as congestive heart failure may actually be a non-cardiac edema.
yes, sir.
If there is no PAH in this patient, then his edema has got to be non-cardiac. Maybe renal
Sir.
failure, maybe liver failure, maybe local pathology like DVT or something like that, or lymphedema, or
Yes.
lipedema. I'm just throwing possibilities, I'm throwing balloons. That is how you need to think.
Yes, sir.
and throughout your history, you cannot forget that your patient was on atenolol. Am I right?
Yes.
And in the neurological examination or even in your diagnosis, you've not mentioned about the stroke anywhere you see. So at least when you're presenting your final diagnosis, it's important for you to mention that CVA that you had said. Maybe your patient had intermittent atrial fibrillation or something.
Yes, ma'am. Yes.
So in
Alright.
presence of significant mitral regurgitation and aortic regurgitation, it's very difficult to miss a heave. I think you need to go back and look into the heave, which anyways a patient of severe MR would anyways have, even if the left atrium is dilated and your patient has also had a stroke, most likely he must be having PAH and atrial fibrillation, some episodes, depending upon the history, the way you have presented.
Yes, ma'am.
Another thing
see.
you have to remember is keeping his 69 years into consideration and a stroke into consideration. You should not forget the coronary arteries.
IHT.
So even though he has a valvular heart disease, he may still be having a co-thief, that is coronary artery disease, which makes things even more complicated for management.
Yes, sir.
Okay.
Yes.
Next, would you like to have ECG, X-ray? Can you go ahead?
It is lead ECG with normal standardization. The patient is in sinus rhythm. With a heart rate of 73 beats per minute, with QRS axis of plus 30 and P axis of plus 40. Here in this ECG, left atrium enlargement could be seen with bifid P waves in lead 2 and negative component bifid P wave in lead V1 with negative component greater than 40 millisecond, greater than one small box in V1, sir. No significant STT changes are seen, and QTC is 470 milliseconds.
One obvious abnormality you are missing, they are uniform low voltage complexes.
Yeah, very obvious. Cannot miss that. How do we define a low voltage? See, it's less than even one box in your limb lead in lead 2. Not even 5.
Low voltage complexes, all the 12 leads, which means something. So how do you explain with your clinical diagnosis in the background?
So in aortic regurgitation, what do you expect? It's a volume overload state. What are the electrocardiographic findings of a severe aortic regurgitation? Do you have them in this patient?
No, madam.
So what's that?
Left ventricular hypertrophy with volume overload pattern. Q waves in V5 and V6 could be present.
A QR pattern, which is not there.
And left axis deviation would be present.
So how do we explain the low voltage? One is there may be pericardial effusion due to heart failure. Or 2, there may be pleural effusion due to heart failure. Or 3, there may be ascites because of a severe right-sided heart failure. Or the chest wall edema. Or if he is a smoker, there may be hyperinflated lungs. Or he has a thyroid issue as well. Maybe he has hypothyroidism, which we have not made out clinically.
Even the BMI you said was 25.
Yeah.
So,
Or the myocardial failure, myocardial disease itself can produce low voltage complexes. Myocardial disease may be due to his valvular heart disease or maybe an independent myocardial disease. Because the only very obvious thing in this ECG on the small screen as I see it is the low voltage complexes. So these are all the various things we have to think. Now, of course, I'm thinking back, is there evidence of any ascites or chest wall edema? Was he a smoker?
Yes, sir.
Yes, for what?
Smoker, sir.
So if he is a smoker, then maybe he has a hyperinflated lungs, explaining the low voltage complexes. But as I see it at the calibration signal, it doesn't appear all right. Calibration signal is not complete. Is it okay on your screen? Because on my screen, I'm not able to see it well.
Yes, sir. Yes.
Okay. Then X-ray.
Chest X-ray PAB taken no rotations. Trachea is in midline. the cardiac borders are maintained and the heart is midline position. The cardiac silhouette is enlarged, suggestive of cardiomegaly. The aortic knuckle is enlarged, sir.
No, you're
In
wrong.
bilateral,
See, in the presence of bilateral pleural effusion, which he has, it is very difficult to say that there is cardiomegaly. Part of you are seeing as the cardiac silhouette may be actually pleural effusion in the mediastinum. This is a parietal, infrapulmonary, and mediastinal pleural effusion on both sides.
yes,
Did you make out the pleural effusion?
yes, sir.
That explains our ECG also, as I was telling earlier.
Yes,
Aorta is dilated, okay, but cardiac enlargement is tough to make on this X-ray because of the pleural effusion. Because it is bilateral, it is more likely to be, when there is a bilateral pleural effusion, they are more likely to be due to heart failure or constrictive pericarditis.
yes, sir.
It is bilateral and almost at the same level on both sides. Okay?
Yes, sir. The
So,
bilateral,
what do you deduce from the X-ray?
the aortic knuckle is enlarged, so aortic dilatation will be present, sir. And there is bilateral haziness and increased bronchovascular markings are present, sir.
There is evidence of pulmonary venous hypertension,
Yes, sir. Yes, sir.
which goes with his mitral valve disease and left ventricular failure. He
Yes,
has
sir.
aortic dilatation, which goes with aortic regurgitation. I won't commit on cardiac enlargement on this X-ray, but from your physical examination, of course, there is cardiac enlargement. And there is a bilateral pleural effusion, which clearly is because of heart failure, and which also explains the low voltage complexes in the ECG.
Yes, sir.
Also, it's an over-penetrated X-ray with, emphysematous lung fields, as you were saying that he's a smoker. Look at the rib cages, which are narrow, and yes, of course, signs of PVH and mitral valve disease, as I said.
Yes.
Is there any calcification visible? Always look for valvular calcification, look for coronary calcification, look for pericardial, myocardial calcifications, because which may be hallmarks of a particular disease.
Yes, sir.
So this is not a great X-ray for those findings, but that is how you have to look for. Put it in a proper language saying that on this X-ray, I looked for these things, but it is difficult to say.
Okay, sir. Yes, sir.
So is there evidence of pulmonary arterial hypertension? There is a clear evidence of pulmonary arterial hypertension. Look at the hilar arteries, look at the peripheral pulmonary arteries.
Yeah.
Are you convinced? Look at the
Yes, sir.
size of the hilar pulmonary arteries. Look at the size of the peripheral pulmonary arteries, intrapulmonary arteries.
They are narrow, sir.
Yeah, there is
Hilar-
evidence of pulmonary
Yes.
arterial hypertension. There is one more thing which you have not described. SVC is dilated. Can you see that? Superior vena cava, right of the trachea.
Yes, sir. Yes, sir. Trachea is-
Right of the right side of the trachea is the thin shadow of superior vena cava, which is dilated.
Yes, sir.
So which means right atrial pressure is high.
Yes, sir.
So this also goes with right side heart failure.
Right side of the pelvis.
Okay.
Yes. Yes, sir.
Can you go ahead to the echo? We just have only, I think we have overstepped the time already. Quick echo if you have. Or if you don't have to run the echo, say the echo diagnosis, read out the echo diagnosis.
I'm sharing the echo on the screen, sir.
Okay? We don't have much time, so go fast.
I'm sharing right now, sir.
We are not able to see here. At least I am not able to see.
No, it's not visible, sir.
It's not visible.
No. You let us know the findings then.
Vamsi, tell the findings.
There is a dilated LV, and no RWMA of LV, severe aortic regurgitation, severe mitral regurgitation. Mitral regurgitation is an eccentric jet. There is a mild TR and mild PAH. There is good LV function, ejection fraction of 60 is present. Grade 2 grade 3 dash dysfunction is present. No pericardial effusion or no LV clot is present.
But they should have seen the pleural effusion on the echo.
So you said severe AR and severe MR, right?
Yes, ma'am.
And normal LV functions.
Yes, ma'am.
And mild PAH.
Yes, ma'am.
That's what they have written, but what is the basis for saying a normal LV function? You cannot go into PVH, PAH, heart failure with normal LV function. So what is the data they have? Do they have ejection fraction, strain rate imaging, LV dimensions, end-diastolic volume and systolic volume? Do they have any of this?
No, sir.
Pardon?
No, sir.
Then how did they come to this conclusion? Because it is completely contradicting the diagnosis of heart failure.
Is it important to know these end diastolic dimensions? Is it very important?
Yes, ma'am.
LV end systolic dimension, end diastolic dimension, end systolic volume, end diastolic volume, calculated LV EDP,
Yes, sir.
right? LA volume index, LV ejection fraction, LV DPDT, because you have MR, LV DPDT. All this can be calculated on the echo. And then strain rate imaging of the LV, which is very sensitive. Even if the ejection fraction is normal, still the subclinical LV dysfunction will be known by GLS, global longitudinal long axis strain. Are you able to follow?
Yes, sir.
Now here there are two important questions. You have two valve disease. We'll not go into the details, but I will give you the questions because we have exhausted our time long back. One question is, when there is more than one valve lesion, you must always see how one valve lesion will affect the other valve lesion. What are the interrelations between the valve lesions? How does mitral regurgitation affect mitral stenosis? How does mitral regurgitation affect aortic stenosis? How does mitral regurgitation affect aortic regurgitation? How does aortic stenosis affect aortic regurgitation? How does aortic stenosis affect mitral stenosis and or mitral regurgitation? So how does tricuspid regurgitation affect left side valve disease? These are all very, very important things because all the criteria that are given in echocardiographic books and all the recommendations that are given for the valve surgeries are based on isolated single valve lesions. They are not applicable for multivalvular disease. So each patient is different. So you have to assess each patient by pooling all the data and putting together symptoms, clinical findings, ECG, X-ray, echocardiography, and then impact of one lesion on the other lesion, LV function, RV function, PA pressures, and then estimate the ATS score of the surgical mortality, right? And whether the patient is suitable for a percutaneous transcatheter treatment, any of them. So all these questions need to be asked. That is very important. So when you are doing an echocardiogram, if you find an ejection fraction which is normal, for example, I don't know what it is in this patient, you say that they have not mentioned. In aortic regurgitation, the typically LV ejection fraction will be on the higher side because it is a hypercontractile LV because of volume load of MR and AR. So even if the ejection fraction is 60, still it means it is LV dysfunction in the context of MR-AR. So don't take 50 as the normal cutoff. That is okay for a normal heart. But for MR, AR, or AR alone or MR alone, 60 is the cutoff. In fact, these days they have revised it to 65. So anything 65 or less than 65, currently they consider as a LV dysfunction in patients with mitral regurgitation and aortic regurgitation. So we have to look for a subclinical LV dysfunction criteria, which may be in the form of GLS or which may be in the form of late gadolinium enhancement on magnetic resonance imaging, or maybe in the form of NT-proBNP or calcium score of the valves.
Yes, sir.
So these are all the various criteria you have to take into consideration before you chalk out the surgical options for any of these patients with valvular heart disease. So in this patient, of course, the immediate goal is to decongest him. Are you not
Yes, sir.
surprised by the echo diagnosis?
Yes, sir.
It is
The echo
grossly
is in
out of the line.
correlation with his clinical findings, sir.
Yeah.
No P. His clinical findings. I mean, of course, the history doesn't match, but he said no PAH, no P2. So echo satisfies his. Yeah. But yes, sir is right, no, because this is what we expect. So
Okay. Yeah. My co-panelists, any further questions before we close?
I think everything has been covered so beautifully, sir. It's so good to have you as an examiner. I think Vamsi is lucky to have been interrogated by your good self,
No, no, I'm
and it's
pleased.
been
I'm
an
pleased to
amazing.
have co-panelists from all over the country. So I'm glad that after a long time I'm taking a Zoom meeting. After COVID, I think this is the first meeting I have taken.
Oh, thank you so much,
Jyotsna
sir.
requested me, so I said, okay, I will take it.
It's our pleasure, and it is really the students who have benefited from this, from your immense experience. You have combined the old with the new, what is latest. So we are very, very happy to have you, Sir Vinkars, and we would like to have you more in our meetings in the future, sir. On that note, thanking both Shiba and Anupam and Vamsi. It's okay. So
Yes.
you go back and you have your homework cut out for you. So sir has told so many things that you have to do. So I hope all that will enrich your knowledge further. Thank you, Medgaming, for this wonderful opportunity, and thank you one and all.